for being here. We're kicking off our monthly Minority Men's Health Program.
Yes, ma'am.
If this is your first time here, welcome. We've been hosting these programs since December of 2022. We started virtually via Zoom. We had anywhere from 12 gentlemen on the line up to 90. And in July, we decided, hey, we're going to transition to in-person because in-person program yields us the highest return. We get to see you, we get to talk to you, you all get to network and share information and resources. But again, it's an opportunity for you all to meet us here at the Emory Brain Health Center on behalf of the Goizueta Alzheimer's Disease Research Center. Last month, I think we had 114 here. Amazing, amazing. Thank you. Hats off to you. Kudos to each and every one of you. Come on in. Thank you all for being here. We're going to try to fill up that side of the room. And as people trickle in, we'll fill in the rest of the tables. I want to first just say thank you to all of our staff, our wonderful personnel. None of this could happen without each and every one of them working. But yes, thank you. Working behind the scenes, getting the layout. It takes a lot of work. And this session is being recorded. So if you find the information very useful, inside the packet on your table, there is a booklet. You got a lot of paper today, right? There's a packet on your table that looks like this. Open it up. On the inside, there's some helpful links. I want you to take the time. If you don't have a booklet, raise your hand, flag us, let us know. But inside, there's some helpful information. There's links in there. That's how you get a lot of our electronic and digital information. Our Alzheimer's.emory.edu website, our Facebook page, all of the ways you can access our center, okay? All right, one more thing, well, a couple more things. If you don't mind, will you silence your phones? If you have an important call to make, just step out the room. But if you don't mind, just silence your phones. Again, we want to be prudent with our time and reduce any distractions. As I mentioned, you have lots of paper on the table. There's a post-event survey there. We appreciate your feedback. So throughout the program, take time to complete that post-event survey. We'll have a drawing at the end. The yellow form, we call those our research interest forms. If you have already completed one, there's no need to fill one out. You've got a crowded room today. Excellent. Okay. The research interest form is how you give us consent to talk to you. And that is our mission here. We want to get as many men of color enrolled in research. So if you've already filled that out, no need to fill that out again. Our staff is working judiciously to try to follow up and check in with you. If you get a phone call or email, you got to call us back. You got to reply. You have to respond. Okay. Welcome, Dr. Monica Parker. Come on up, Dr. Parker. Give us our marching order before, I think we're going to look today and do a really quick number, and then John is going to come on. Welcome. Thank you.
Good morning, everybody, and thank you for returning. I want my research participants to stand up. This is important. I need my research participants to stand up. Don't stand up if you're not a research participant. Where are they? Can our attendants look at these men? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. That's less than 10% of this room. That's a problem. Okay? So we're happy to educate, inform, and empower you. Thank you, gentlemen. Please sit down. I hope you all took note of where they were because we've got a special something for you. Maybe you'll get it today and maybe you get it every time you show up. Okay. But for everybody else, you're slacking, okay? I need your name on a research interest form, but more importantly, I need your name on a consent form. If you don't want to do a lumbar puncture, you don't want to do drugs, we're not going to do drugs anyway, right? I need your name on a consent form for somebody's National Institutes of Health, National Institute of Aging research project somewhere. Why? Because that's the way you learn how to be a better consumer of healthcare. That's the way that you get better healthcare from the system, wherever it is you choose to get it from. Jane Morgan says you get good care if you have a doctor, you get optimum care if you're in a research project. So you pay, the taxes that you pay are going toward funding Alzheimer's disease research centers and other disease-centered places that do research. Your tax dollars pay for research. That doesn't mean we're going to give you anything. We have to apply for all of this, but you need to take advantage of what your taxpayers, your taxes are paying for. That being said, we do this every month for men of color because you are missing in research. You are missing, or I should say, well represented when it comes to chronic diseases that are poorly treated, managed, and otherwise taken care of. We die disproportionately from those diseases which, when they managed well, don't cause death and disease or illness, chronic comorbid conditions. So our men's health discussion is designed to help you learn a little bit more about what you need to do for yourself and not so much about what somebody else needs to do for you. Am I clear about that? So if I don't get your name and we don't get you on a consent form somewhere, I really don't want to see you anymore. Because you're taking up time and you're wasting my time, my money, and your money. That being said, we can go on with the show.
Hey, morning, evening, afternoon. For the new people, the rule is go at your own pace. If it's something you can or don't want to do, don't do it. But if the doctor says you can't do a little bit. All right, for all you golfers and anything you want to do, this first piece is the most important piece, is stretching. It's stretching. Any sciatic nerves, back problems, shoulders, hips. We need to stretch it. If you feel like you just crip it, let's stretch. Here we go. Go. Exhale. Exhale.
Quick. You think we'll stay faster.
Next wide, down.
Burning it
Up.
down. You know I'm keep me safe.
Smooth. Great. Arch like a cat. Great. Arch like a cat. Great. Right leg. Ready. Because the moment is
We're all so glad that you revved us up, gotten us out of breath, and for those of us who used to, maybe can still kind of maybe, and wish we could have, wish we could still. There's still hope for us. Right. So at this time, I'd like you to bring before you the man of the hour, Dr. James Law, who is director of our clinical core, who is the principal investigator for the Emory Healthy Brain Study. And responsible for my change in career. So he's going to talk to you about research participation, yes, but more importantly about what most of you are here to learn about. What's going on with my brain? Why isn't it working well? What has research taught us? Is Alzheimer's in people of the color the same as it is for people who aren't of color? So, Dr. Law.
Thank you, Dr. Parker. Thank you all for being here. And thank you, John, as always, making me look like I got no rhythm. So I decided, I asked Dr. Parker if I should have these slides, and she said, sure, have a few. So I didn't create a whole slide deck or anything, but I just created a few slides just so we could use them as points of conversation. There are several specific topics that I wanted to cover with you all today. And so I'm going to get a couple of things out of the way. So something that everybody always wants to know is, well, what can I do? I don't want to get Alzheimer's disease. And since you all are here, we're going to tell you the secret. So I can tell you two things. If you do those two things, I promise you, you will not get Alzheimer's disease. Want to know what those two things are? You can't spread it around too much now. So first thing you got to do is be very careful when you choose your parents. Second thing you got to do is don't get old. Guarantee it. Now, some of these things that are associated with risk of getting Alzheimer's and other dementias are things that are out of our control, obviously. But there are certain things that are under our control, and I want to just highlight those before we start talking about other stuff. So, and I was telling Crystal that during one of these upcoming sessions, you ought to invite one of my colleagues to talk with you about CTE, chronic traumatic encephalopathy. That wasn't what happened to Damar the other day, but certainly with athletics and head injury, those are major concerns. But anyway, there are things that we can do. So next slide. This is from a report that was released a couple years ago. And what's really important about this is going over those things that we have under our control, lifestyle factors that can substantially reduce the risk of dementia as we get older. And in this case, early life refers to before the age of 45. So we know that people who don't get a good education are at higher risk of developing dementia later in life. And 7% of all dementias, they estimate, can be eliminated by making sure everybody gets a good education. And next slide. During middle age, between ages of 45 and 65, there are another series of things that can be done that will also substantially reduce risk, including taking care of hearing loss. 8% of cognitive decline and dementia can be avoided by eliminating problems associated with hearing and communication, managing chronic conditions like hypertension, avoiding excessive alcohol intake, not letting yourself get overweight and obese. Those things can all contribute to reducing risk during middle life. And next slide. And then in late life, you see the associated features after age 65, including smoking, depression, social isolation, each of which contribute significantly to dementia risk. Next slide. And you add all those things up, even without medical advances or anything else, by taking care of those modifiable risk factors, up to 40% of all dementias worldwide can be eliminated. 40%. That's a lot. That's a huge number. And then there's a component that we don't yet fully understand. And I'm going to talk to you a bit about circumstances and populations in which we know even less in terms of those unknown risks. So next slide, please. Now, the second topic that I want to make sure I cover, because I want us all to be on the same page on this. So Alzheimer's disease is a chronic disease. So Dr. Flowers knows that when somebody comes in and has an MI, a heart attack, that didn't start day before yesterday. That happens because over a period of years and decades, the blockages in your coronary arteries build up, those atherosclerotic plaques that block normal blood flow in your heart. And if that gets severe enough, over many years, that winds up giving you a heart attack. And we have now come to understand that Alzheimer's disease is no different from heart disease, colon cancer, any other chronic condition. And this is just a graph that shows on the slide on the left are something called amyloid plaques. And then next to it is something called neurofibrillary tangles. And those lines represent the buildup of those pathologies in our brains. The green line, all the way to the right, is when symptoms are first starting. So when you get to that mild cognitive impairment or MCI, and then progressive worsening of memory loss, cognitive decline, and functional decline, and that is progressive dementia. That doesn't start for about 20 years after the pathology has been building. So it's been building silently for 15 to 20 years before symptoms actually start. So this is why I say this is a chronic condition, just like heart disease or colon cancer. So how many of you went and got your colonoscopy when your doctor told you had to do that? You guys are better than me. But I'm going. But the reason we do that is because if your doctor does a colonoscopy and finds a little polyp and snips that sucker out of there and caught it while it was something called carcinoma in situ, you're in good shape. You're cured. But if you let that thing grow and spread and become a chronic metastatic cancer, you're in big trouble. And so where we are with Alzheimer's disease to this point has by and large been identifying people and treating them at the equivalent stage of treating metastatic cancer. And we all know that that's a losing battle, right? So this is a really important concept. And then I want to talk to you a bit about something called biomarkers or biological markers. And biological markers is anything that we use to reflect an underlying disease. So cholesterol is a good example. So when you have your cholesterol checked and your doctor says, well, your bad cholesterol is way too high, or your good cholesterol is way too low, we worry about those things because we believe that those good and bad cholesterol levels are a marker for risk of heart attack and stroke. So those are things that we can measure. In Alzheimer's disease, there are two changes that occur universally in people who have Alzheimer's disease. So when we look in the brain, we see these amyloid plaques, that big blob in the center of that picture, and these things called tau tangles or neurofibrillary tangles. And those are actually black blotches that are inside brain cells. And those pathologies are universally present. So every time we see look in the brain of somebody who died with Alzheimer's disease, we're going to see those changes. And they're made up of these two proteins, this amyloid protein or amyloid beta protein and this tau protein. Next slide. And we can measure those proteins in something called cerebrospinal fluid. And that's that clear liquid that's being collected in that syringe. And that part of a butt that you see, that's my butt. And so we can collect this spinal fluid, and I'll explain why, but we can measure amyloid and tau in that spinal fluid, and we can tell whether or not somebody has Alzheimer's disease in his or her brain. So if we have high levels of amyloid and low levels of tau, that means that we're very unlikely to see Alzheimer's disease inside the brain. But if there's low amyloid and high tau, that tells us that the brain does harbor Alzheimer's pathology. Now, this is an MRI scan cut down the middle of somebody's brain, and all of that white area that surrounds the brain and the base of the brain, that's all cerebrospinal fluid. So that stuff is in direct contact with our brains, and it's made inside the brain pretty quickly, actually, about 20 milliliters every hour. And then it circulates down along the spinal cord all the way down to our lower backs. And that's how we collect the spinal fluid. Now, there's some joker that's been running around from town to town. I don't know, maybe he's in here. Anybody here know somebody who got paralyzed after a spinal tap? You heard that? Because there's some joker who's been running around telling that to people everywhere. And the reason that's impossible is this. If you look at that cartoon on the left, that yellow thing that's kind of coming down the middle is the spinal cord. And the spinal cord only gets down as far as our first lumbar level, the first lumbar spine. And then all that length below that is below the spinal cord. And we collect the spinal fluid either between L4 and L5 or L3 and L4. So it's physically impossible for us to actually hit the spinal cord. And the reason the spinal cord's that high up is because when we're born, our bodies grow and elongate much more than our brain and spinal cord does. So as your body grows, the brain is attached to the spinal cord. So as your head goes up, it carries the spinal cord with it. So that's why there's that big length in the lower back where we can safely collect this spinal fluid. And that's what we've been doing. So, and one of the things, among our research volunteers, that's the one that causes the most trepidation, most concern. But the reason that we want to do that is because by measuring these proteins in the spinal fluid, we get insight about what's going on inside the brain. So I said that pathology may be silently present, Alzheimer's pathology, for 15 to 20 years before people develop symptoms. And that's reflected in spinal fluid that we collect from healthy volunteers. So what you're looking at here on this plot are the proportions, the percentage of healthy individuals that have served as volunteers with us here. Healthy individuals who have evidence of Alzheimer's pathology based on those spinal fluids. So you see between the ages of 50 and 55, that proportion is pretty low. But by the time we have individuals, normal, healthy individuals over age 75, that's almost a third of healthy people with evidence of silent Alzheimer's pathology. And currently, there are a couple of other tools that we can use, but as a practical matter, the spinal fluid is our best way of detecting silent pathology, detecting the presence of pathology, whether it's symptomatic or silent. What we can't do, and this in a nutshell, I forgot when I made this slide, but in a nutshell, this slide represents the reason that we're doing a good bit of the research that we're currently doing. And that is, I can tell from looking at those spinal fluid proteins whether or not those plaques and tangles are present inside the brain, right? But if we just say that it's a 20-year course, a 20-year journey, if I test that and the answer is yes, I don't know where we are. It could be tomorrow that symptoms are going to start, or it may be that symptoms are not going to start for 20 years. And then on top of that, when you look at the brains of people who are completely normal when they died and they donated their brains, you see lots of people who have pathology. About a third of the control brains that we look at have abundant evidence of Alzheimer's disease, but they never had any symptoms during life. So the other thing that we have to be able to say is, okay, this person has pathology and she or he is or is not going to develop symptoms during life, because if they're going to be fine when they die, who cares if there's pathology in there, right? So those are the two questions that we desperately need to answer. One, does this person harbor Alzheimer's pathology? And then two, is that person going to develop symptoms? And if so, when? And so those are really critical questions that we have to answer, because there are treatments that are developing that are going to allow us to alter the course of Alzheimer's disease and in the not too distant future, prevent it. All right. So this is something that we hear a lot, and we actually communicate a lot. And the last few months, I've been bashing my head against the wall, trying to make sense of some of the data that we've been getting. And I haven't even told Dr. Parker this yet. Where is Dr. Parker? Yeah, I haven't even told. She's going to be a senior author on this paper, and I haven't even told her yet. But it hasn't been published, so you can't go spreading this around, okay? So we know that the rate of individuals with Alzheimer's disease is going to increase quite dramatically. So these are estimates from the CDC. And if you look at individuals from different racial and ethnic groups, compared to non-Hispanic whites, there is a substantially higher risk of dementia. Now, mind you, I'm saying dementia. This slide says Alzheimer's disease. Okay, and this is what I've been bashing my head against the wall about. But we do know that clinical symptoms of dementia are much, much more common among African Americans and among Hispanics compared to non-Hispanic whites. All right. So that's what the CDC says. That's what the Alzheimer's Association says. That's all of our publications say, that the risk of Alzheimer's disease is higher in certain populations. Now, this is some data that we've generated looking at the cerebrospinal fluid. And when we compare the cerebrospinal fluid among Caucasians and African Americans, so people who self-identify as white Caucasian versus self-identify as Black African American. And the African Americans are circled in the purple. And those dots represent the levels of the amyloid protein in the spinal fluid and the tau protein in the spinal fluid. And what you see there is that among African Americans, the levels of the amyloid protein overall is pretty comparable to what we see among Caucasians. But when you look at the levels of the tau protein, it's about 25% lower. And this is something that's been reported a couple of times in smaller groups, but we've looked now at, we have probably the largest group of African-American patients and healthy controls, healthy volunteers who've donated their spinal fluid than any other place in the world. And so we have the numbers to look at this, and this is a rock solid result. There is no question that levels of the spinal fluid proteins are different between Black people and white people. But there are things that we don't know. And I mentioned the spinal fluid data that we have that others don't. But this goes across the board. And I don't want to say it was an epiphany, but it was a realization that gradually came to me that has profound implications. Whether we're talking about Alzheimer's disease or cancer or heart disease or anything else, our understanding of those conditions comes from studying those diseases. And whether you're talking about heart disease or Alzheimer's disease, the data are overwhelmingly from white people, overwhelmingly. In fact, I mentioned about those autopsies. Across the country, the NIH sponsors a group of Alzheimer's centers. We're one of, I forget how many there are now, 33 or 4. And there's has been for 40, going on close to 50 years now, collection of brains that have been donated by research volunteers. The brains are overwhelmingly from white people because, for lots of good reasons, African Americans have been understandably reticent and untrusting of researchers and medicine. And so it was a lot harder, frankly, to get people to participate and to donate brains. So what we think we know about Alzheimer's disease is what we know about this disease in older white people. That's just the reality of it. And so when we look at results like this in the spinal fluid, that spinal fluid test is something that I use in clinic every day to make a diagnosis. So if I see somebody who has symptoms and I'm not quite sure if their symptoms are due to Alzheimer's disease or if it's just aging related changes, subtle changes, I'll do the spinal fluid test and I'll interpret it based on the data that we have. And the data that we have is based on Caucasian populations, people of European ancestry. And so if we know that the levels are different, I'm using the wrong numbers to make diagnosis when I see patients in clinic. And then equally importantly, we depend on these to identify people who are going to be at risk of Alzheimer's disease. So people who have that silent pathology during that critical period where we might be able to intervene to prevent or delay the development of disease. And so we're hamstrung because of the lack of data and lack of information from diverse populations. Next slide. And this is a really simple question. What causes dementia in people? As part of the same analysis that we've been doing, when I look at the diagnosis that people get from our clinics upstairs, patients that we've been evaluating, if I compare Black patients versus white patients have way, way, way higher frequency of different diseases like frontotemporal dementia, something called Lewy body dementia, or Parkinson's disease and dementia. They occur in Black folks, but at a much lower rate than what they occur in white patients. On the other hand, vascular dementia, cognitive problems, and dementia symptoms associated with a vascular injury to the brain, hypertension, stroke, those kinds of things can damage the brain and cause vascular dementia. And the rate of vascular dementia is way higher among African-American patients that we see than among Caucasians. So there are differences. Next slide. And then this question, is Alzheimer's disease really more common in African-Americans than in Caucasians? Without question, dementia and cognitive decline is a bigger risk. It occurs more frequently in Black folks than in white folks. There's no question about that. And the higher rate may be as much as 80 to 100%. But the Alzheimer's disease, the plaques and tangles, is that truly 50 to 80% more common among Black people than among white people? That's a really hard question to answer. Any statisticians in here? Come on, no statisticians? Nobody knows what Gaussian mixture of regressions means? Not one of you, come on. Took me a long time to figure out how to use Gaussian mixture of regressions in a sentence correctly. But there are ways of using data because the part that we have trouble with is if we're looking at something, whether it's spinal fluid protein levels or any other result, and we say we want to set a threshold value on this test to be the most accurate at classifying people into different groups, you have to say, well, what's the gold standard? How do you know what the truth is? And if the truth is dependent on pathology, well, most of these people, we don't know what their pathology is. If the truth is based on expert clinical judgment, that's faulty because I'm flawed and my judgment is going to be wrong. And not only that, my judgment may be flawed in different ways based on my own biases, depending on who I'm seeing, who I'm evaluating. So the tricky part is there is no real gold standard to tell us how to classify results. And so what we use is a data-driven classification so that we just let the data tell us what the different groups are. And that's what this modeling is. And the reason I did that modeling is because when I used the numbers based on cutoffs from something called ADNI, the Alzheimer's Disease Neuroimaging Initiative, which is 95% Caucasian, non-Hispanic white, and I just looked at the healthy controls, and there have been published estimates, and overall the prevalence, the frequency of silent Alzheimer's pathology among our Caucasian controls, normal Caucasians in our cohort, was about 13%, and that's in line with other published results. But when we looked at our cognitively normal African Americans, using that cutoff, remember this cutoff is based on data from white people, the rate was only 8%. And I said, well, see, this is what happens when you depend on flawed data. We're missing a lot of Black people who have silent pathology because we're using the wrong numbers. And so that's why we built this data-based modeling, and the model looks very good. It kind of corroborates everything that we've seen. And so we use that model to classify people instead of using that single cutoff value. Well, guess what? The rate of silent Alzheimer's disease among our healthy Black volunteers was even lower. It was half the rate of what we found in the Caucasians. The model found almost the exact same number as the cutoff among healthy white people. So this is, when we submit this for publication, I expect that I'm going to get a lot of pushback because this is contrary to dogma. This is, everybody knows that Alzheimer's disease is more common in Blacks than in whites. But when you go and look at the data, that data is not based on biomarkers. They don't even use imaging. It's based on clinical criteria that were created back in 1984. And so it is flawed in that those judgments were made based on relatively shaky, inexact classification schemes. And I think that when we start looking with these biomarkers, in fact, I think that's going to show what I showed or found. Yes, sir.
Also flawed because you don't have enough Black samples.
That's exactly right. So the question was, are the data flawed because we don't have enough Black samples? Yes, they are. We have enough in this sample set. I think we had 450 cognitively normal African Americans. So it was a sufficient number to put into this model. But all of the underlying data, and we'll see, this has to be validated in an independent set. Those independent sets don't exist because nobody has the samples to run an analysis like this. So this is why we ask you to do these things. The fact that we have based our medical beliefs on results that come from research that is overwhelmingly in one group of individuals puts us at risk of having these blind spots and believing things to be true that maybe are absolutely not true. And so, if 2 years from now I'm still working on trying to get this paper published, it'll be because the establishment isn't quite ready to make these leaps. Yes, sir.
The new drug that they've come out with, one is that the results, that drug has come about as a result of more of the people that have been in research back when, and then we know Black people were not involved. So the results are primarily as a result of the white involvement. And the second part of the question is, what in your presentation would that drug alter?
So the question has to do with the new drug that you all have mostly heard about probably, but a drug called lecanemab or Leqembi that is going to be approved. It's got an accelerated approval and it's going to get standard approval from the FDA later this year. And the question had to do with the foundations for that drug, the development of that drug. What was the second part of your question, Karen?
How would that drug
how would that alter things with it? Yeah, and how is that different among African Americans? So this latest study was a little bit more diverse than studies that had come before. What it did, though, was it's dependent, targeting the amyloid protein, which I think is appropriate. I think it's completely appropriate. But that's based on decades of work, which, of course, was dominated by certain groups. But the clinical trial enrolled individuals who were at early stages of disease, very mild symptoms, and had evidence of Alzheimer's pathology. Right, so it wasn't just based on clinical judgment. We knew that they had Alzheimer's pathology, and those individuals, about 5% were African Americans in that study. There was 20% Hispanic participation and a significant number of Asians because it was an international study. So the representation was better. And we believe that if it doesn't matter if you're Black, white, yellow, brown, doesn't matter. If you have Alzheimer's pathology, that drug will go in there and it will remove that amyloid out of the brain. And it looks like it will slow the progression of disease if you do that early enough. The problem is that the drug is associated with up to 20% risk of having some swelling or even microscopic bleeding in the brain. The level of that risk in different populations is unknown. We're making that estimate of 20% based on the predominant racial group that's in those studies. And so there's a lot of unknowns, but it doesn't mean that these drugs are not applicable to African Americans. We just have to know who we should be treating, because we don't want to expose people to risk with no expectation of benefit.
Hey, Chairman, Dr. Law, he has one more slide before he finishes his presentation. We're going to get to your questions. Could you please just kind of write them down and hold them until after he finishes his last slide, and then we'll have some time for some Q&A. Thank you all so much.
So the reason I put this next slide in here is, all right, so Jim, if you're telling us that there are differences between groups, what's driving? Is it genetic? What is it? And there is some genetic component to it, but something that you're going to be hearing a lot about, and something that we're going to be focusing a lot of attention on, is something called social determinants of health. So this refers to everything in your life experience: where you grew up, what the air quality was, what your family income level was, what your access to education was, what stressors you experienced while you were, DWB or shopping while black. All of those exposures, the stresses and hormonal changes, air pollution exposure, nutritional quality, educational quality, all of those things play a huge role in our health and wellness. And I believe that as we go forward, we're going to find that these social determinants are as important, or maybe even more important, than genetics in driving differences in different groups in terms of risk of disease, as well as the likelihood of wellness. So that's my last slide, and I'm happy to do whatever you guys tell me to do.
Yeah, thank you so much, Dr. Law. Give him a round of applause. Always good information. So here's how we're going to do this. Just let's make sure we have our questions formulated in a question and not a statement today. We're not going to necessarily have time for a large-scale discussion, but we do want to answer your vital questions as it pertains to the presentation. So I'm going to start with this gentleman over here.
Say, for instance, you're an organ donor. Well, when you die, you don't know where your parts are going. So do you have to make a specific designation for where your brain goes, so you can get part of that study?
So thanks you for that question. The brain donations can be done a couple of different ways. The way that we do it here is we try and process everything in a consistent way. And so if you give us consent to collect your brain at the time of death, the most important thing that you have to do is tell your family. Because in the state of Georgia, you can't consent to donate your brain or anything else until after you're dead. So, but yeah, we have a process in place, and we're going to make sure that we disseminate information about how to be a brain donor.
Dr. Law, thank you for your presentation. It was very good. At one of your earlier slides and your last slide that listed the multiple risk factors, one area was the education and access to education. And the data presented show that in African Americans, if that's a risk factor, of course, we're lower. But I wanted to know, what is the correlation between those risk factors in terms of the dementia that comes later?
Good question.
So that's a great question. And I don't think that, as far as education goes, I don't think that's specific to, that's not specific to any particular race or group. And this is data that's been pretty well established for many years, that individuals who have less than a high school education have a significantly higher risk of developing some form of dementia. And the reason I think that is the case is education is a surrogate for what we do during our lives. So if you are not well educated, you're going to be much more likely to have a not mentally challenging job during your life. And one of the things that we think is really important for sustaining brain health as we age and also being resistant to the effects of disease is brain activity. So we need to keep our brains active. And so if you have more education, then you're more likely to be in a occupation that gives you more stimulation and more challenge. And we think that that is a healthy thing for the brain. And I will also add that it's not just, it's not, don't go and say, well, I'm going to finally finish that damn New York Times crossword puzzle. Don't do that if you hate it. What you want to do is do things that are stimulating, but also meaningful to you. So if I don't think retirement's good for us, but if you do retire, make sure that you plan on doing something that continues to challenge you and also continues to give you a sense of purpose and engagement in what you're doing.
Excellent.
I like to add a comment to that. Basically, well, he said retirement. He shouldn't have said that. I retired, okay? So that's
he didn't ask me before he did that.
That's a good example. People ask me, what are you going to do? I tell people I'm working about as many hours, not working, but I'm doing activity and other stuff about as many hours as I was when I was working. Like I'm director of a food pantry at a church. I do community education at various churches. Helping out here. It's important to keep your brain active. If you don't use it, you'll lose it. And another part of that equation is that people with less education and less access to care, they don't get as good care as you should or would have gotten. For instance, if you were diabetic and if you wasn't aware of the fact that you should get an A1C check, or you go to the doctor when I grew up in Mississippi as a kid, we went to the doctor when we were sick. Okay. So if you, for instance, had diabetes, and we know that diabetes is a risk for getting dementia because of the vascular component that is a sequela of having diabetes, just like with high blood pressure. So if you say didn't know that you were drinking a lot of water and going to the bathroom a lot and urinating a lot, you never paid any attention to finally got to be so bad you went to the doctor. Well, by the time that happened, you've had diabetes for a couple of years already. And that diabetes has been working on your body. So education is very important to know. And that's what we're trying to get you guys to do here, to be educated. We're trying to educate you guys. And I think Monica made a statement earlier, Dr. Parker. She said, we want to educate you guys so you guys can take better care of yourself. You don't go to a doctor so the doctor can take care of you. You go to the doctor to get information to help you take better care of yourself. Reading a book every day. Some type of physical activity, crossword puzzle, current events, all that stuff keep the brain working as opposed to retiring, going, sitting there and watching the football game and taking a nap every 2 or 3 hours.
That's very, very good point. Very good point there in terms of education and also activity continually after retirement. I have one question for Dr. Law.
Thank you, sir. And actually, that's a perfect segue into my question. First of all, thank you for bringing up the social determination health factor, something I've never heard. And I'm convinced that we're just not, susceptible to this. It's because of our diets and social, so on. My question is, per those stats, would that be the same in other countries that have Black men?
We don't know. So there have been some limited studies looking at things related to Alzheimer's in something called the Yoruban cohort, which is a African cohort, because genetically, obviously there's an admixture among American Blacks, and so we just don't have the data from African populations or Black populations in other countries. So again, it's the lack of information.
Okay, right over here. Okay, right here. You need the mic?
Yeah, just a quick question. I was listening to the presentation, and you said that amyloid plaque, the new drug is supposed to help with the amyloid plaque. But in your presentation, you said the tau numbers were different in African Americans. So would that be a determining factor of just the effectiveness of the drug on African Americans?
I don't think so, but again, because the participation rates are so skewed, we just don't have enough data to do what's called a segregated analysis. So if we had sufficient numbers, we could look at different populations. We could look at men versus women. We could look at Black people versus white people. But when there's only 5% of the entire cohort that was in the study that were Black, we can't make that assessment. When you look at the study as a whole, with everybody that was involved, the results are significant. It looks like there's a 25 to 30% slowing of Alzheimer's progression when you remove that amyloid. And we know that we can identify the presence of the amyloid. We know we can identify the removal of the amyloid. How much does the difference in tau impact the outcome of removing that amyloid? We don't know. We just don't know. And that's why, Dr. Parker's getting tough. If you don't sign up, she don't want to see you.
Yes, yes.
But her point is a good one. Unless we can fill in these knowledge gaps, we can't answer some very, very basic questions.
Yeah.
One question here, and then we'll go over to that side.
Yes, Dr. Law, can you address brain plasticity and the implications for perhaps treating or even preventing dementia?
Yeah, that's a great question. So we think about brain plasticity. What that refers to is the changes that are happening in our brains throughout our lives. In fact, sometimes I just kind of think that, your brain, when you leave here, is going to be physically different than what it was when you got here. So everything that we do, the things that we think, the things that we feel, the activities that we engage in have an impact on our bodies and have an impact on our brains. And so the things that we think are the best stimulating things for inducing plasticity of the brain to continue to grow and develop are things that keep your brain active, new things. There are different ways to induce plasticity. So if you chop off my right arm, my brain will represent my left arm differently because it's not going to represent my right arm anymore. So there is this plasticity that's inherent in our nervous system. It's most vigorous when we're young, but it never stops. It never stops. As long as we're alive, our brains are reacting and responding to whatever you do, what you eat, your activities, what you think, who you interact with, how nice you are to me and to Dr. Parker and to Dr. Flowers. All those things going to impact what your brain looks like.
Okay, I had a question about you had a slide with the MRI, and you said the spinal tap was in within the ridges. Are you saying that African Americans have a pathology of those ridges in the brain that leads to a tendency of Alzheimer's along with these other points?
Well, so the slide on the spinal fluid, what we can say is that the levels of those proteins that we measure in the spinal fluid are different. And the really complicated part about this, the reason it's damn science, is trying to interpret what these things mean, and so the levels of the proteins being different in the spinal fluid of African Americans versus Caucasians tells us that something is different. But it doesn't tell us why those things are different. I think one of the reasons may be that the prevalence of different conditions are different among different populations. Dr. Flowers alluded to diabetes, hypertension. Diabetes and hypertension are way more common in Black people than in white people as a whole. And those things predispose us to all kinds of changes, just like all those other social determinants. And that's why I think that your exposures to medical conditions, your exposures to opportunities, education, healthcare, all of those things through your entire lifespan impacts what's happening to our brains when we're in our 70s and 80s. And so we just need to be able to answer that question by doing more research and having a better understanding of different populations.
Dr. Law, I think we have time for maybe 2 or 3 more questions. So this side, and then we're going to go back over to this side.
Oh, let me come in on that question this gentleman asked, and maybe, I don't know, maybe you asked him, you see all that spinal fluid in all the parts of the brain. That proves that whatever is going on in your bottom part of your brain is also going in the top part of your brain. Just mean that the spinal fluid that you see in your spine, it communicates with all parts of your brain. Just like if it was raining outside and you have an umbrella, it had a hole on one side and not on the other side. You get wet on one side, but this one there's no umbrella. So you can get wet everywhere.
Yeah, and I may have failed to answer your question correctly. Our bodies make about 20 milliliters of this stuff every hour. The total volume is somewhere less than 200 milliliters. So the entire fluid volume, it circulates from inside the brain down, back up, gets reabsorbed, and the whole volume turns over a couple of times a day. So I'm sorry if I misunderstood the question.
Dr. Law, thank you for your presentation. My question is regarding what you highlighted with regard to the differences in groups. You acknowledged that there's a disproportionate participation rate, and so that makes sense. But I'm curious to know, in a room full of men, what the data shows with regard to gender.
Oh boy, when in about a year, we're going to have a women's health group discussion. So one of the reasons that we're doing this is we have had pretty good success over the years. Dr. Parker has really led this since, she and I started working together back in 2008. She's really driven our engagement with the community, and we've done very well overall connecting with African Americans. The place where that was not true was among Black men. So consistently across all groups, more women than men participate in research, because we all know women are just better than men. But among our Black participants, it was like 80-20, 85-15. And so we said, this is the toughest nut to crack. But if we don't tackle this, then we're not going to be able to interpret results for Black men. So that's a great question. The women thing, one of the things that I've been really interested in is the effects of hormones and menopause, because we know that about 2/3 of people living with Alzheimer's disease are women. And there's some pretty good data to suggest that there may be a linkage between hormone therapy at menopause and risk of dementia in late life. And so that's something that we're actively trying to evaluate right now. So there's some really, really interesting sex differences.
Yes, I wanted to ask a question. The young man that plays football for the Buffalo Bills, what happened to him? Would that eventually affect his brain?
Let me answer that for you.
And I'll tell you why I asked it when you're answering.
Okay, let me explain. Let me tell you know about the CTE, the whole thing about getting head trauma, and then if you was out, they take you out of the football game, and then they have to do evaluation before you get back, make sure you got everything together up there. I still think they are going back too early. When your brain is injured, if you take your hand and hit that wall, it'll be a little bruised and red and a little blister. And if you hit it again within a minute or two, it's gonna get worse. It's gonna be a worse bleed or blister. But if you let your hand heal completely and decide to go hit that wall again in about a month, it won't look as bad as it would have looked before. So bottom line, it's cumulative. The injury you get to your brain over a short period of time become cumulative. And in regard to that young man the other day, did not, it wasn't because he had head injury. He had a direct hit to your chest. And when you have a direct hit to your chest, depending on what part of the EKG has a QRS component, depending on what part of that cycle you're in, your heart will stop and then fibrillate. Essentially, you're dead. And so you have to quickly resuscitate a person like that. Now, should he play football again? Or yes, of course, I think that's going to have some impact on his future. How much? Depending on his whether or not he go back and play football, or his physical contact with hitting to the chest. This is nothing new. I have personally had patients with this happen to them. One guy playing soccer got hit in the chest with a ball. High school student have died. I had my insurance agent's son died in high school, got hit in the chest. But we are beginning to recognize these things now. That's why we have you guys here to educate you on dementia and memory problems. We don't know all the answers to all the memory problems and dementia. We need research. We need to get data so we can better do it. If you could look in the time warp, if you look at us 30 years from now, you'll look back and say, those guys were stupid. This is what was going on. No, you laugh. I can tell you in my lifetime, 40 years of practicing cardiology back in the 80s, very clear. You don't give black folk beta blocker ACE inhibitors. That's what they said. But now we know with research in black, but there were no black folks in the study, we know that that's a drug that you must give. In fact, you don't give it, some lawyer going to be saying, why did you give this guy? We're almost sue you for $20 million. So we are in the learning curve. So you need data to make a good decision. We as providers make decisions based on what data we have. And sometimes, like Dr. Law say, we might not make the correct call, not intentionally, but we are using the data we have to do the best we can with the situation.
Yes, as far as the outcome for Damar, a lot of it will depend on how long his brain was deprived of oxygen and blood flow. But early on, it sounds encouraging. It sounds like his recovery is encouraging.
Okay. The reason why I asked that question, about 3 years ago, I was in North Carolina. I was visiting a relative. His birthday. One of my mother's brothers. And about 12 o'clock that night, something happened to me. And last thing I remember was calling my wife's name. The next day, I was in the hospital. And I was told the only reason why I was there because they couldn't pronounce me dead in the hotel. They had to take me to the hospital to be pronounced dead. And I asked you about the brain thing. Did I lose something?
Yeah, you did. But
what did I lose?
Let me explain something that is missed. You remember when the guy got hit, right?
Yeah.
He got up and he went down, right? Okay, his heart had stopped when he got up. The heart pumped blood to the brain and give the brain nutrients. The brain is going to work for just a minute, a little while before it gives away. Brain's not working after, like when people die from cardiac arrhythmia, we have to resuscitate. We say, how long he been down? Been down 5 minutes? That give us?
No.
No, I'm just saying in general. that give us an idea. We generally say if you've been out for less than 3 to 5 minutes, then you got a good chance that we can bring you back and you're going to be all right. I've had patient who was out a longer time. They come back and they'll completely, their brain go crack. I mean, they don't know where they are. That's completely, cognitive dysfunction is severely impaired.
Can I just say how very happy it makes me to hear a cardiologist confess that the main reason the heart is there is to pump blood to the penthouse.
Yeah, that's it.
That is true. That's exactly heart. That's a pump.
Okay. Do you believe in miracles?
Yeah. So I believe in miracles.
Yeah.
I think what we call miracle is great thing that we can't explain. We call a miracle.
Okay.
That's what a miracle is.
Well, I believe in miracles because I can't explain it.
Well, that's what I said. Right. Right.
Like I said, they took me to the hospital, pronounced me dead. I woke up the next morning, snatched everything out of my throat.
Yeah.
And asked, what's going on?
Yeah.
Yeah, that was obviously a question and a statement that was close to quite a few of us hearts, because that was the same question that he had, was male, female, similar. Where can we go? Here? One more question. We're going to go over here to the center of the room.
I have a question. I went to my neurologist last year, and they did a lumbar study for potential Parkinson. And the fluids that they took out, would it be the same, or were they tested for something different?
Well, the fluid is the same. I don't know what they might have tested for Parkinson's, because we don't really have very accurate spinal fluid tests for Parkinson's, but the fluid is the same. In fact, we're trying to discover things in the fluid that we collect that will give us more accurate answers and better predictions. So we're using that same fluid.
Okay, thank you.
Okay, that's gonna, I apologize. That's gonna include our Q&A session. We are so happy that so many of you are here, interested in brain health and all of the other things that are associated with this men's program. And now we're going to turn it back over to Dr. Parker for some statements.
So now we brought you here to educate you so that you can be empowered to ask more questions and take the initiative to see after your own health. Now, we do promote research, and that's what we're selling. And I use that word because it is a sales job. But more importantly, we want you to have the information that you need. You've got a bunch of forms. So remember when I said I don't want you wasting my time? I don't want you wasting my time. If you've got a yellow form and you are interested in participating in research, fill it out. If you're not interested in research yet, you don't have to. But if you have filled out one of these forms and you wish to be contacted by one of our coordinators, and the lead coordinator back there is Miss Latasha Chapman. Tasha, would you stand and make yourself visible? Okay, chances are, if you fill out one of these forms, Miss Tasha is our lead research outreach coordinator for all research studies coordinated through the Alzheimer's Disease Research Center. So she takes care of people that don't necessarily look like any of us in this room. She takes care of the people that come through the clinic and are referred to studies. For the purposes of these gatherings, Ms. Crystal Davis, where's Crystal? There she is. Don't you do that to me. She is the coordinator for the minority men's discussion group. So if you fill out one of these forms, Ms. Chapman or Ms. Davis will be calling you back and inviting you to some other events. Now, and what they do, and I'll let Tasha tell you what she's going to do, but within a week or two of your filling out and completing that form, one of those persons is going to call you, ask you some questions, and do some over the phone kind of testing to just see what you're eligible for. Now, when it comes to the drugs, we talked about the new drugs that the FDA has approved. None of you are candidates for that in this room, I don't think, because you have to have a clinical diagnosis of pre-Alzheimer's, mild cognitive impairment, and you have to have already demonstrated clinical evidence for having Alzheimer's. So if you don't have any of that, we have to get you to that point where we can find out what you've got. So Tasha can tell you a little bit more about the follow-up process, but I want to make sure that you're clear that when it comes to drug trials and the Alzheimer's Association, everybody says, we want you in a trial, we want you in a trial. But there is clinical criteria that is required in order for you to be in a drug trial. And for the purposes of this meeting, none of you are eligible for them. Got it? Because we don't have evidence that you have something that needs to be treated with these drugs, these investigational drugs. So what we like to promote is observational studies. And the Emory Healthy Brain, the Emory Healthy Aging studies are observational studies. So our longitudinal study for aging is called the Memory Study. And that's where we take people age 70 and above, and we bring you back every year. We test your memory and we check you for things. Check you for memory loss and other things. We ask you questions about how you're doing, what your function is. And in the course of being a part of that long-term aging study, that memory study, if you're 70 years in age and above, we will ask you if you want to get a lumbar puncture. We will ask you if you want to get a PET scan, because one of the things that we've gotten now is we've gotten money to get people who are already in that memory study one of the PET scans. Now, if you've been to our program before, you know that that amyloid PET scan costs more than $6,000 per shot. It is not covered by Medicare. It's not covered by Medicaid. It's not covered by private insurance. The only way that you generally get an amyloid PET scan, which is the only FDA-approved diagnostic tool for determining whether or not somebody has Alzheimer's, is if you're in clinical research. So if you're a part of that memory study, and Dr. La has been working on this, we are going to get 60 people to get at least to get a PET scan. Getting an MRI, which is just laying in the tube, is one of the things we do. But for the brain study, as Dr. La has explained, we do an imaging. And for most of our research studies, it's an MRI, correct, Tasha? And an option is to get the lumbar puncture and get the cerebrospinal fluid collection. That's where we measure the biomarkers that Dr. La talked about, the A beta and the tau biomarkers. There are studies, several studies that we have here that collect those things as part of research. And it's like, okay, I can't be a part of that study. Can I be a part of another one? Ms. Tasha will tell you how that is done. So if you, I did this myself for one of the NIA studies, a head study, because my mother has Alzheimer's. She's 96. She's still with us. She doesn't know my name and she doesn't walk, but she's still with us. The problem with my mother having a diagnosis of Alzheimer's means that I'm at risk. Thank God I don't have any of my mother's risk factors. I'm not hypertensive. I don't have a diabetes. I've never had a stroke. But I'm interested in the studies and I'm interested in early onset or early diagnosis because I want that drug if it works and it prevents Alzheimer's. Now, Dr. Law said you got to pick your parents. Well, my mother's 96, almost 97. So I'm probably going to be here. I just want to be here with all my faculties, right? I want to wipe my own behind. I'm sure you do too, right? Important. And if you can't, you better start looking around in your families and figure out who you're going to get to do it for you and do it right. That's being real. I'm a primary care doctor. That's the biggest issue with caregiving. Who's going to take care of? Who's going to take care of? Well, better figure out who's going to take care of you and your family that you don't want to pay or don't want to pay, but get prepared. In these days, dollars, it's $26 an hour to have a home care attendant come to your house and take care of you. And then they don't have to do the job.
So as Dr. Parker stated, the process is we have two forms that we want you to complete at this time. We have the usual post-event survey. Many of you who already attended before, you know this. This allows us to know, receive feedback from you, things that you like, things that you would like to see, additional topics, what we can improve on. That's the way we are able to bring quality programs to you. So please, it's 3 pages. Make sure you put your name on it, because that is how you're eligible for a gift card drawing. But please put feedback on it. We're going to give you a few minutes. Please put your thoughts down. The yellow form is the way we contact you regarding research participation. As Dr. Parker has said, the process goes that if you filled out a yellow form, I will be in contact with you about a special program for you to come and talk to us about your interests, ask additional questions, and to sign up for research. It's going to be a direct invitation for a special program if you complete that yellow form. So if you have any additional questions before you leave, you can come up and ask us. And then in the meantime, also myself and Tasha will contact you if you fill out that form and let you know what the next steps of screening are. Tasha, if you want to add anything at this time.
Yes. So I want to tell you guys what to expect when it once we contact you and receive the information. The first thing that's going to happen is a pre-screen, and typically that is just getting your family history, like asking about your mother, father, was anyone diagnosed with any type of cognitive impairment. Then we're going to get your demographics and your medical history. As far as like medication, anything you've been diagnosed with or surgeries. Then from there, we're going to schedule for a TICS, which is considered a telephone. Yes, there we go. Yes, and that is where we're going to do a memory assessment on you. The memory assessment typically takes about 15 minutes, and this is where it'll be a series of questions like counting backwards or asking you the opposite of like hot and cold and different things like that. And this will be your time where you can ask any questions if it's a particular study that you heard about or you want to know how often the visits are. This is that time where you can just ask that information, and we will provide you with brochure and all the different studies that we currently offer.
And just a quick note, a couple of things. If you've already ever filled out a yellow form, you do not need to fill one out. We will contact you or in the process of contacting you. You are in our system. Someone will reach.
I want you all to know that you're all very special people, and we're going to do our very, very best to take very good care of you. Whether you're a research participant or not, we're going to take care of you. I'm saying that because we're building in some accountability, which you may not find at a lot of other academic research centers. I'm here. I'm a primary care doctor. Dr. Flowers is here. Dr. Law is here. And one of the things I think you need to know so that nobody brings up the Henrietta Lacks or the Tuskegee thing, and I don't want to hear it. I don't want you to hear it. It's old news. Okay, we have institutional review boards that are designed to protect research participants. Research is to be done ethically. We're not to take advantage of people. And if we find diseases, we're to help you get those diseases treated and addressed. This is not the era of Tuskegee. This is also the era of accountability. So something that's happening here that it hasn't happened in any other academic center in a long time. People say they do this, but they don't do it. They talk trash. We're accountable. If you tell me, you tell Dr. Law or you tell Dr. Flowers that you have a health need, and if you need help getting it addressed, we're going to help you with it. If you are in our research program and we discover that there is something abnormal that needs to be addressed, we're going to tell you about it. And if you don't have a doctor to help you get that addressed, we will help you find one. That's my statement of accountability to you. So that is my bit of transparency for you. I have a father, had a father. I have uncles. I have brothers. I have a husband. I have a son. And I wish that somebody had taken as good a care of them as I take care of my husband now. I do. He's been sick. But more importantly, my father was a native of Georgia, and my grandfather was illiterate. Comes from Washington, Wilkes County. How many of you are familiar with that? My grandfather was illiterate, and I didn't understand that he was illiterate until I was 16 years old. But that's what we were talking about when we were talking about education. If you don't understand what the system is, what the process is, you can't access it.
If you don't know what you should eat, you don't know that you should exercise, you won't. So your healthcare is going to be bad. If there's not somebody around to tell you that you can get screened for prostate cancer or colon cancer, you're going to get diagnosed with those things late in the game. And there's only going to be some research that's been untested that may give you some relief, but it's not going to bring you a better quality of life or extend your days. That's what happens to people of color. We get to the game late, and then we want everything expended to make us stay here when we could have taken advantage of things that prevent disease and wouldn't have been in that position in the first place. So that's my big message to you today. If you don't have a primary care doctor and you need one, we're going to help you find one. There are preventive health measures and strategies that people can use to keep themselves from dying from disease prematurely. And that's what we need you to do. I want you to participate in Alzheimer's research, but if you have high blood pressure, you have diabetes, you have heart disease, you need to address that. I can't do that for you. You need to do that.
Okay, I would like to say something here today. Research, when you hear research, you think it's a bad thing. But for all you got, I would like to have 100% participation here in research. There is something called the Healthy Age Study. It's what the Healthy Brain Study eventually came out of. All it is answering some question. All you got to do is just answer some question on the computer. Ask before you leave. I wish each one of you would get in the Healthy Age Study. It's collecting data, just answering some questions. I say this because for you guys who have never done the research, that's called research. It's sort of get you in the mood for doing things and understanding how things are done. And I think if we understood things better, I think we'll be better participants. I think a lot of times we don't do something because we either are afraid or don't understand. And there are different kind of research. There's kind of research where you just ask questions. That's one type. There's one where, like the Healthy Brain Study, where you actually come in and get blood and maybe the spinal tap. There's other where they actually give you a drug or chemical. This is not the blood or chemical. The Healthy Age Study just answers some questions on the computer.
Yeah, very good point, Dr. Flowers. So what directive are we leaving here with today? Y'all heard Dr. Monica. What's the directive? Remind me. That's long term, but what do we need to do today? That's right. Get those yellow forms filled out. Okay. If we don't do that, I'm going to be in trouble. Everybody else going to be in trouble too. My name's David. I'm 57 years old, and I will be doing my teleconference in 5 days, which is my streamline into the research. So I want to give you all who are in participation with research and study program a round of applause, but also, hey, give me some love, man. I'm a young man stepping up.